Yeah, good morning. Good morning to all of you. Uh, I welcome you all on behalf of Rheumatology Association Gujarat. Rheumatology Association Gujarat is a family, and we organize this kind of meeting conferences as a mix of academics and fun with a very eco-friendly heart. And Kunal has worked hard for this. Uh, I just read a couple of days ago a Nobel laureate's quote that scientists are attracted by mysteries, and I am sure that we all are attracted by mystery of immunology part of allergy. And in my career, all these years, when I look back, so many patients complain of allergy, and it was like my response would be, oh, it is some kind of allergy. It is some kind of allergy. But after attending all these pre-conference talks, I realized that there is such a wonderful, you know, wonderful universe of cellular biology underlying the allergy, and it is very fascinating. And I hope that in next 2.5 days you will enjoy this voyage of discovery of allergy. I welcome you all, and I invite Dr. Pushkar to set the stage.
Thank you, Dr. Chakani. First of all, I would like to inform everyone that today happens to be even Dr. Chakani's birthday. He was like immediate past president of RAG, and this is a very special day for him when we are starting this conference today. The most important thing, we are all here to learn allergies, and if you are practicing allergy, then asthma definitely forms a very big chunk of it. And because asthma forms a very big chunk of it, we have created this workshop specifically targeting pulmonary function tests in allergies, which is essentially asthma. So when patients come to us, they have very variable symptoms, and we know that asthma is a very variable disease, and all those things are very subjective in nature. So we have to have some objective criteria, we have to have some way in which we can label them, we can give them a number with which we can diagnose them, and then we can follow them through. So pulmonary function test therefore becomes very important because it provides us objective data in the management of these patients, and this workshop is trying to address that part. So we'll be conducting 3 important workshops. The first would be on spirometry, which will be taken by Dr. Talwar. The second one will be on oscillometry, which will be taken by Dr. Bala. And then Dr. Talwar will again take fractional excretion of nitric oxide. How do we use that in our clinical practice? And finally, we'll go for an integrative approach, and we'll have demonstration of these devices which are present here. So without delaying this much, I'll call on the organizers to start the session for today.
Good morning, everyone. I would like to welcome our faculty members who are going to chair the first session, Dr. Shabir Chikani sir, Dr. Kirti Thalari, and Dr. Argya Chattopadhyay.
Yeah. So we'll start with the first talk about spirometry, and I welcome Dr. Talwar on the stage. This is his CV. As you can see, there are so many publications, so many citations, and Dr. Talwar, if I can again look back at my career and my postgraduate days, the spirometry that I carry for a rheumatologist, spirometry means FVC, FEV1 and DLCO. That's it. We don't understand anything more than that. So we will definitely like to learn more about nuances of spirometry. The stage is all yours.
So, thank you very much, and organizers for having me here. First of all, if I say that when I saw this invite which had immunology and allergy, the first thing which stuck to me is that I haven't seen this before. So how the allergy and immunology are working together, and when the concept unveiled with the program coming up, I felt very sorry that I can't sit through the entire 2.5 days. I have to be in Hyderabad tomorrow and Mumbai on Sunday. So next time, if you do such kind of thing where immunologist and allergy people are together, please send your email intimations so that we can block those dates and don't do anything else during those days. Because there's no better way to learn than to learn from people who are working in the same field with much more specialization, more focus, and a small little things which you learn from them. Actually, you can never learn from the books or from any other place. I can say that very of course, from the rheumatology perspective, I think I don't miss any rheumatology meeting, because I can't practice pulmonary medicine without rheumatology, because my almost 25% of practice is actually rheumatology only related to ILD. No, this is not the one. This is the second presentation. Yeah, this is the one. Yeah. Correct. So I can change now. Yeah. So this is a workshop, right? So there is no question of anybody sitting on the back. Please move forward. This is a workshop. Please move forward. There's no silence required for any purpose. So please come ahead. Please don't shy away. Please come ahead. Don't leave the seats vacant in front. Let people who come late occupy those seats, and devoid of a direct eye-to-eye contact, which is very important in the workshops. Please come forward. Please come forward. Now, second question I ask is, how many of you are actually doing spirometry, or in your department spirometry is being done? Raise your hands, please. Raise your hands, please. Raise your hands. So I will say almost about 70% of people are actually engaged in it, and maybe the rest one are in the process of getting engaged into it. So that's why all you are here. You need to justify that. So I don't think so we can practice if a patient complains of anything related to respiratory system without a screening tool, which is actually a spirometry. I won't say that we have reached the level where we can think of any alternative tool or alternative test for that. Spirometry would still remain the first and the foremost screening test. A lot of you are already doing it and know it very well, that this test is introduced to us in our curriculum right in physiology, the first year of our life in the medical college, when it is a physiological test, and it just, how much and how much you can inhale and how much you can exhale and how fast you can do it. That's all. I think there are 2-3 words into it. Not very tough. Very old thing. I think the most important thing to remember is the spirometry is nearly about more than 150 years old. So this is definitely a test which has stood the test of times. And it does only 2 things. If you remember these 2 things, you can't go wrong. How much of the air you can exhale out maximally, and how fast you can do it. So there are only 2 words, much and fast. So it is only considered about 2 things. Volume is to be taken out, how much, and how fast is the time. So there are just 2 things involved in it. And it measures 2 most important parameters, which are the vital capacity and the volume of the gas which has been expelled in the first second, which shows that, you know, how fast and how forceful you can do it. So it has got, you know, if you see the machines out here, the spirometry report can contain almost up to, I think, 27 parameters. Actually, you don't need them. They are very, very confusing and they do not add anything. And most importantly, lot of them are effort dependent and will be of no value in your interpretation. You need very little number of values to be considered and very simple algorithm to follow. So we do spirometry because it's a non-invasive test to look at the respiratory function. That's what we have been taught in the physiology. It is readily available, yes, of course. Now it has become so cheap, from something like big spirometers, which were like tanks, to something which is like very, very small handheld ones, which would be out here. You can see that, which can be compactly put into a briefcase and you can carry it anywhere, you can have it anywhere, you can, in your office, in your clinic, anywhere you can use it. So, and of course, it's very cheap also now. Then it comes the sensitivity. It is really at, if we are calling it, it is a screening test. What is a screening test? Screening test is highly sensitive, but you may be compromising on the specificity. But sensitivity should be above 90%. And we have almost reached there. So that's why it's a highly sensitive test, which is done to measure the lung function. And then it comes that the most important thing, that what are we looking at? We are looking at two things. Is the spirometry normal or the spirometry is abnormal? Only two words you need to define. And if it is abnormal, then that means the air flows are limited. And then our job is to see whether it is obstruction or it is restriction. Not much from spirometry. Expectations are not high. And still, we find there is a lot of gaps in not only understanding it, but also using it. But also, now we know that the gold, when it talks about COPD, it talks about doing spirometry because it can pick up the diagnosis of obstruction much earlier. Much earlier means even 10 years before the patient will develop the symptoms that there are obstruction. This is, I think, everybody who does a spirometry will be very shocked to see a patient who comes up with lung functions almost like 60%, and they're walking around and you ask them and they say they have no problem at all. Of course, God has given two lungs. Chop off one, nothing happens. You will continue to have a normal life till the time you age, and with aging, you decrease your capacities down and down and down to 50, and you start developing the symptoms. So early detection, potential to change the trajectory of the disease. That's the most important thing. If you pick it up early, you can change the trajectory of the disease. You can modify the course of the disease if you act where it is still possible to reduce the decline, which is going to happen in these patients. So this is something which you see in spirometry. So there must be students out there. I ask them, but anyways, I will, for the sake of time, I'll quickly go to it, that we have these capacities, we have these volumes. Everybody knows that? Everybody knows from physiology, of course. So capacities are total lung capacity, the entire air which is there in your lungs, entire air. Very difficult to do it out. What you do it out is actually the forced vital capacity. So that's not total lung capacity. So some amount of air will be still left behind. And you have an inspiratory capacity also to it. So we have capacities, but lung volumes are also important. And what cannot be exhaled out and can never be measured on the spirometry is a residual volume. And if you do not have residual volume, you cannot calculate total lung capacity, because total lung capacity is vital capacity plus residual volume. So this is the drawback. The spirometry will never be able to give us the complete estimation of the lung volumes. All of you are familiar with this? All of you are familiar with this, so that I can skip this, because this is the tidal volume. Take a deep inspiration, go to the maximum, which is the total lung capacity, exhale out as much as you can. Whatever is left behind is the residual volume, and this is the entire one spirometric procedure. And you need to do 3, you can go up to 8, because you need the ones which are matching with each other, the criteria of acceptability, which I will tell you later. In spirometry, we get these two types of curves. I'm sure everybody knows about these curves because these are the curves which came first to us when there were old spirometers. So you just exhale out, and this is the time on this horizontal axis. Keep doing it. They're saying 6 seconds. Now they are revised it to 12 seconds, and they are even going beyond that. Patients are there who can still do it 18, 20 seconds, and sometimes we feel that they will faint, but they don't. But yes, if a patient has something else, then of course they can faint. But yes, 12 seconds is now considered, but generally less than 6 seconds is not acceptable. That means some more air could have still come out, but then you need to look at the curve. If the curve was going flat, then you might still agree that it is possible to interpret that. Otherwise, less than 6 seconds, discard it. Then it comes the flow volume curve. So these are the two types of curves which will come out in the spirometry. And again, you can see that this is the expiratory curve which goes to the peak, which is peak expiratory flow rate, and comes down till no more air can come out. And that's the area which is going to be the residual volume. You will be leaving behind that. And this is going to be your vital capacity maneuver. So these two kind of curves will be the ones which we always get in spirometry, and we need to remember that. When we do spirometry, we do need to remember when not to do it. So we don't do it if the patient is having active hemoptysis, patient has got pneumothorax, patient has got unstable cardiovascular function, like patients with acute myocardial infarction. Previous contraindication used to say that up to 3 months after the post-myocardial infarction, but now they are able to reduce it down even to 6 weeks. Hemorrhagic stroke, as well as within 1 month of acute myocardial infarction, as I said. Some relative contraindications or when not to perform is when the patients are puking, having a lot of abdominal pain, dementic who cannot be explained how to do the procedure, because this is one procedure which is going to require a lot of coordination from the patient. And if the patient doesn't perform that, then obviously the test is going to be wrong and the interpretation is going to be everything wrong. So it is an effort dependent test. Effort dependent means you need a lot of coaching and poaching of the patient that he does the test properly. So the technical job, the technician's job is really a very, very tough, and he needs to be a hard master. Recent cataract and retinal surgeries are also relative contraindications, and generally they allow us to do it after 1 month, but we even delay a little later because we give them clearance prior to going for surgery. Again, abdominothoracic surgery. Now, when we do the test, the most important thing is, why are you doing the test? Tell me. Anybody? Why are you doing this test? You are trying to see if there is anything abnormal or not, right? And what is that abnormality which you put by 100% on spirometry is obstruction. If the patient is already on drugs which relieve the obstruction, then this spirometry can come out to be absolutely normal, and you might be misguided that this patient doesn't have anything. So it has happened many a times that we just interpret that, oh, this is a normal spirometry, you look so well, there's nothing wrong with you. But because he is on medication, so you need to withhold, and you need to remember this rule. All short-acting drugs, whether it is salbutamol or ipratropium, 6 hours. All long-acting drugs like formoterol, salmeterol, 12 hours. All extra long-acting drugs, vilanterol, tiotropium, glycopyrronium, all of them need to be on hold for 48 hours. So the question is, some patients are not, you're seeing them, they are already on drug, and if you withhold them, they can actually develop worsening. Are you ready to accept that? No. So in that situations, you can go ahead and do the spirometry. Can anybody answer why in those patients you are allowed to do it? They are already obstructed. Something will definitely come on spirometry. So this kind of withhold is actually most important for asthmatic patients. Mild asthmatic, intermittent asthmatics, or mild to moderate intermittently asthmatic patients. So you need not withhold the drugs. Don't lose the opportunity of doing the test on the day the patient has come to see you, because he might not come back again to get the test done. Might as well do it and mention this, that this test is performed while the patient had taken drug A, drug B, drug C, at what time, and what is the time of the test. The clinician will be able to interpret that. Ideally, we tell them don't take caffeine, don't take cigarette smoking, 30 minutes. But our lab offers them coffee because they are waiting there and they are wasting time and they are getting very much fussed about that how long time it is going to take. So they soothe them out by giving coffee. So I think Nitin only told us once that the coffee is not to be given, right? I think both with the pheno as well as this, the coffee is not to be given to them. So we replace the coffee with simple plain water. We tell them we'll give you coffee a little later on. So this is the guideline now. If the patient is on therapy, you can still do the spirometry and still go ahead and do before and after. So after means obviously after bronchodilator. Then it is also done in follow-up patients. And when you do it in follow-up patients of asthma, the GINA 2025 says, don't withhold the therapy. Do it once you have diagnosed, now on therapy, and see what is the residual obstruction still there. What is the levels of the exhaled breath nitric oxide after your treatment? Does it need upgrading or it's need downgrading of your treatment? And there it makes sense not to withhold anything. And if you are doing it on therapy, then the question comes, should you still do a post bronchodilator test in them? Very valid question. Answer is yes. You still have to do it. Because if you are able to pick up that on treatment patient is still showing reversibility, that means your treatment is inadequate. You need to upgrade your treatment there. And then of course for the follow-ups in COPD, very important thing. Many a times we are confused. This is like COPD or asthma or overlap. So once in the follow-up, on treatment or without treatment, if the spirometry becomes normal and crosses the thresholds of FEV1, FVC of less than 0.7, that means patient is not COPD and it is asthma only. And immediately it will change how you are going to look at the patient for the rest of his life. He has that one opportunity to actually able to make through the wrong label where it is asthma, COPD together. You want to say something? Okay, right. So, of course, this is the graph which clearly tells you, you start with the normal tidal breathing, small ones, 500 ml, and then you ask them to take a deep breath as much as they can, and then exhale out forcefully, as fast, as hard, and as long as you can. So remember, please, 3 words are there. As fast, as hard, and as long as they can. So there are 3 words which are very important. So I think it will be demonstrated onto this spirometry. And then of course you need to inhale it back so that you are able to reach the total lung capacity. And if this does not match, then there is again something wrong, either leak or there is something which has happened to the patient in a way that he has not done it properly, that it did not meet that. Because then it is not a total lung capacity. And if you do not do at a total lung capacity, then your volume, the FVC as well as FEV1 are going to be wrong. So remember that each and every step of this is very correct. So I'll demonstrate you how to do it. It is not easy, right? Everybody says that, okay, we can do it, there's no problem. I'll exactly tell you. So I am asked, I'll tell myself. So breathe normally, okay. I have a little high breathing because I'm standing here, but I'll try to settle down. Normal breathing. I'm trying to take as much as I can and fill my chest as much as I can, and then I stop there. And then I have to breathe out as fast, as hard, and as long as I can. So see how it is going to be there. Seconds. I did develop wheezing. I am asthmatic. So you could clearly hear the wheezing. But it has to be that tiresome. Can you understand? I'm sweating. It is a problem. But if you don't do this test like this, then the reports are not going to be good. That's the most important thing to remember. A well-performed spirometry is only worth interpretation. If it's not been done, then you are nowhere. So I think some of you will tell, okay, our technician does it. How do we know? Normally the technician is supposed to write that this was a suboptimal effort. Otherwise, we will see how we can see on this. So as I told you, when you start from the zero line, it should immediately rise. So the forceful expiration should be very fast and as hard as you can, so that this peak comes in very, very quickly, and then this smooth exhalation process goes on and on and on and on. So, you know, in the last part, the sound stopped coming. You could all hear it actually. There was no wheezing sound of my coming, which means that perhaps the air is not coming out. But a little air is still coming, and even if there's another 50 ml, it is going to make a difference. So if it is going to be 50 to 100 ml in the next 2 seconds or 4 seconds, it's still going to make a difference. So continue that, because it seems that you have stopped, but it is not, unless and until you close your glottis. At that point, it will be suddenly dropping into zero, which you can see clearly. And then of course you inhale. So 6 seconds is minimum. If you have not done 6 seconds, you have not done the job properly. Some patients can't do 6 seconds, people generally tell me. But as far as our lab is concerned, I do not know, maybe 30,000, 40,000, 50,000 spirometries, not even one less than 6 seconds has been accepted. No. They can do it, only thing is they need time, they need coaching, and many a times the person who's not able to perform is made to sit to look at the other person who's doing, and then he is able to perform it. Because it's difficult for them, as they have never done it before. You have to do at least 3 procedures which should be matching within the maneuver and between the maneuvers. So within the maneuver, of course, some artifacts should not be there, and many other things which we are going to discuss later. And of course, between the maneuver, the difference between the FVCs of the 2 of them should be less than 150 ml. And the largest FEV1s too should be less than 150 ml. So the difference between the 2 values which you have taken, there should be, difference should be less than 150 ml. So the max and the next to max, first and second, the difference between them, the largest and the second largest, should not be more than 150 ml in FVC or FEV1. But if it is very low, patient is very badly obstructed, FVC is very low, then even 100 ml match is acceptable. So these are the 2 curves. Anything wrong? Anybody can pick up? Anything? Sorry, just say whatever it is. Incomplete. This one. Absolutely correct. It is incomplete. You can see that this curve is still going up and up. It has not reached. It's only 4 seconds. If it would have gone, it would have added maybe another 100 ml into it. It would have changed the diagnosis here. What's wrong here? Cough. Yes, there are multiple coughs which have come. This one is a bigger one because he has even inhaled into that. These were like little bit of, kind of reverberations of the vocal cord which happened because of some trying to do cough, but it is not there. So you need to inspect your curves when you are interpreting it. And if there are wrong curves, then obviously wrong interpretation. You can't send the patient back. Then you need to be cautiously interpreting them. This cough artifact, will it make any difference? Say yes or no. Yes, no, it's not. Because FEV1 will be finishing here. The most important thing is FVC, which is there. FEV1 is here. This is going to come to FEF 25 to 75, which is a value for small airways. But we don't look into that because small airways will be oscillometry now. That's why, because it is effort dependent, you cannot rely on these values to pick up small airway dysfunction. No, because this will change according to the effort of the patient. So that's why it is not important, right? Good. Now, these are a lot of abnormal things. I'm sure if anybody picks up them, they should be given some kind of a rewards. Is this okay? What is the one? Anything wrong in this? Say yes or no. No, good. Perfectly. This is the good test. Very nicely done, and see 2 procedures done which are overlapping each other. So intra-maneuver and inter-maneuver acceptability again seen here. Perfect. Is this normal or abnormal? Abnormal. What is abnormal? Yes. This peak has not reached. No. That's it. The peak is not there. Next, what is there? Anybody can tell this? Yes, efforts are different, and some of them actually they have not reached the TLC. They have not. The premature termination has happened there, right? This one you have already picked up. This is a cough. Cough artifacts sometimes do come, and you cannot avoid them completely. But only thing is, it should not come within the first second. If it's beyond the first second, your values are not going to be affected. Okay. Then you have this one. You see this? This has to be within 0.05 second. And this has taken such a long time. Patient is leisurely doing the test. Not suffering through the test, leisurely doing the test. That's not the spirometry. Wrong. This can never interpret correctly FEV1 because very less volume has been given in the first second, because first second will be here. So maybe just 50%. So it will give wrongly the value of FEV1 50%. This, anything? Very good. Suddenly the guy has stopped here. And then drop straight and starts exhalation. Most commonly seen in females. They will just stop. Vocal cords close, finish. They will just inhale at that point of time. Sudden drop. This is glottic closure. And this, of course, is submaximal again, because the patient has started from where it is not reached completely, you know, from here. And there is a gap here. The inspiration finished there and expiration again had to start from there, and this much of volume was missing. So this cannot be correct at all. And then finally this, these are the rounded ones. They give you a very false impression that patient has upper airway obstruction actually. But this is again a submaximal where patient has not done it properly, or the tongue has come into the mouthpiece. Right. So you do reversibility. So as I said that never to do just simple plain spirometry. Even if the baseline spirometry is normal, you can still have reversibility and still can prove that this patient has asthma. Please remember that. Most of the labs, the moment they find a normal spirometry, don't do after, because they think it is normal and nothing will come. It can come in asthma. So you still need to do that. Please remember that. It should be a standard thing. I do not know why people talk about only baseline spirometry. Only baseline spirometry is for COPD. Where if you do not get a baseline spirometry is normal, then you will say no COPD. But does it tell you that patient has no asthma? How can? Asthma is a variable disease. Patient can have absolutely normal lung functions today, and tomorrow he might come up with an acute attack. So if today he shows a normal lung functions, you can't say that he doesn't have asthma. You can only say that his asthma is under control today. I don't know what is going to happen tomorrow. So every patient we have to do reversibility test, and reversibility has been changing, you know, people have been changing. FEV1 or FVC more than 10%, 12%, 15%, 12% is the standard one, but European guidelines have changed it to 10% and 200 ml. Volume is a must, because if the FVC is very low, like 30%, then FEV1 will definitely show 20% improvement, but in volume it will be only 80 ml. So it does not. So both the percent as well as the volume criteria must be given. And you need to give the reversibility medication. So 4 puffs of salbutamol or 4 puffs of ipratropium. Now these days everybody is checking for anticholinergic reversibility also, not only just salbutamol, because that is also a treatable trait in a patient. Whether you have asthma or you have COPD, how does it matter? If an ipratropium gives you a response, you need to be on anticholinergic. What's wrong in it, right? So only difference is if you are checking with ipratropium, you have to wait for 30 minutes, for salbutamol for 15 minutes. That's the only difference. And remember, if lung functions are very bad, 30%, 25%, we see 16%, 13% FVC. You don't expect FEV1 to be showing a good response in any case. So remember that these patients will require a long-term monitoring to tell you which way the things are going. So this is the interpretation steps. That first thing to be seen on a spirometry is the ratio, which has to be 80 or 80, below 80. And if it is 80 and above, then obviously that means there is no obstruction. So the first parameter is FEV1 over FVC. 80% and above means no airflow obstruction, right? Then what can it be? For that you need to check the FVC. If FVC is low, then it is a restrictive defect. If FVC is also normal, it is normal. But if FEV1 over FVC ratio is decreased, obviously then you look at the FEV1. If that is also reduced, it is obstructive. But lastly, very important is in this step also you need to check for what is the FVC in the last step. FEV1 first, FVC will come later here. And if FVC is low, then it's a mixed defect. So you can see that you can have obstructive defect, you can have restrictive defect, and you can have a mixed defect. So I will just skip this and go to grading. Grading is mild, moderate, severe, very severe. This is standard machine does it. I won't waste time on that. Yes, I'll come to complications. What complications can happen? I have seen in my life, starting spirometry in 1983. With the complications coming up, patients will faint, they will die, they will develop myocardial infarction, they will develop this, all that. Yes, pneumothorax can happen. If there is already a bulla, it can rupture. Intracranial pressure can increase for a very, very good procedure done, and sometimes patients do get lightheadedness. They do develop syncope, but maybe in 10,000 patients, one will develop that, but very unlikely. And of course, chest pain, which is mostly muscular, not myocardial infarction. Cough is the most important thing. You need to take care of infection control in your laboratory. And of course, if you are doing a spirometry in a patient who's on oxygen therapy 24/7, you need to discontinue that. And that was the old guidelines. But now we don't discontinue them. Actually, we continue them with the oxygen also. We don't discontinue that. And of course, bronchospasm can be given. So then the next question comes, what is the normal? And which are the equations which we are going to use? This is a very difficult question. I cannot answer this question because every person who's looking after the group of patients will have a different profile. If your patient's profile actually matches the Western standards, you really need to use the Western standards. If your profile is where you see the patients which are matching the general population, where you need to change the normals. So, various equations are available. Indian equations are also available. North, south, east, west, everything is there. We tried all of them. But incidentally or accidentally, all those applications, all those kind of regression equations which are available did not match to our standards, and ultimately we had to go on to the Western standards because they are only able to match the group of patients which we see in our laboratory. So you need to choose yourself for that. And now of course the guidelines says use lower limit of normal. So lower limit of normal is like it is already calculated, you know how it is given. It is a fixed fifth percentile, lowest 95th confidence interval. But the question here is, always interpret spirometry as per your clinical data. And then whichever fits in best, try to utilize it. Don't underestimate, don't overestimate, but most importantly, don't miss it. Because lot of things might look normal, but they are norm. Because the lung functions are affected by age, height, sex, and origin. The restrictive lung disease, I'll just leave that. And if you get this rounded kind of curves on the flow volume curve, most of the times, you know, we say it is because patient has done this only, nothing else. But it is indicative of actually upper airway obstruction. And if the curve looks like this, where it is cut both in the inspiration and the expiration, the entire thing is rounded, then it's a fixed airway obstruction. Otherwise, you will see something like this, in which the inspiratory is gone, and you can see that chewed up inspiratory loop, which is in extrathoracic variable obstruction, and the expiratory limb is chewed in what is called as the intrathoracic variable obstruction. I'll leave this. Okay, so now this is for you people to read and tell me, who is the volunteer? I have time or I have finished?
You have 10 minutes.
10 minutes.
10 minutes.
So these are the exercises. Who is going to be the volunteer? If you don't, then I'll ask the head of the departments or the senior people to choose the ones who are going to be there. You choose. You tell somebody. Everybody is so scared. You can't, even if you go wrong, how does it matter? It won't matter at all. Why are you so scared? Is a volunteer there? Raise your hand. Everybody is so, see, this is called enthusiasm. Please, you tell me what is it. You can come near. You can come near. Yeah. This is workshop, no? This is not a teaching class, I suppose. This is a workshop. People are supposed to learn here. Even if you go wrong, how does it matter? Come. I'm telling you, you can't go wrong. Yeah, 100% I can tell you. I'll handhold you, right? The first thing I told you is to look at the FEV1 over FVC ratio, right? So everything has been, placed in a manner in which you can look at it, and they are even predicting this. Can you believe it? 68 to 79. I am going to ignore it completely. I come straight to this value. This is pre-bronchodilator FEV1 over FVC ratio, which is 59.07. Is that right? Sorry? It's low. So if it's low, it means it is obstruction, right? That was the chart which we showed. And then you look at next what? We have seen the FEV1 over FVC. Now we look for the FEV1. So we go into FEV1 and we find it 67%, right? That's low again. So it confirms that this patient has obstructive airway disease, right? And then finally we go to FVC. FVC we reach here, and we are reaching here to 96%, which is normal. So it means it's a purely obstructive defect, right? You got it? Clear? Okay, now tell me, is it reversible or irreversible? Because that's the second part which we have to do. Yes, so this is pre and that is post, and this is the percent change. So you can see here, you can go near, you can see that 10%, correct, and volume wise. As I said, 10, 12, 15% are the three which are various guidelines using it, but the volume has to be more than 200 ml. So 1.58 to 1.74. So how much it comes to? 160 ml. So it has not reached 200 ml. So the report will go as a partial reversibility. It will not. Patient may be either on treatment, then you have to interpret. If this patient is on treatment and is an asthmatic patient, which it looks like, I really need to upgrade the treatment for this patient because he's still showing reversibility. You got my point? But if this patient is a COPD patient, I'll say this is just a borderline reversibility, which can be seen in such patients, and I will like to follow this patient, and if his lung functions become normal on follow-up, that means he doesn't have COPD, actually he had asthma, right? And of course, asthma COPD is something which we always talk about, is just an overlap kind of a thing. Then very important, before you start, actually, you need to see the graphs. Are the graphs good or not? So you can see that very nicely both have gone. Something wrong has happened here. That is because of the patient's efforts. But this can be completely ignored because this is beyond 1 second. It doesn't matter to me at all because it's not going to affect my FEV1. And as far as FVC is concerned, because these are just reverberation, doesn't matter to me. So it is fine, acceptable. And you can see the inspiratories also, they are all doing perfectly fine. So the spirometry is acceptable as well as a good quality test, which shows obstruction, partial reversibility. Yes, if suppose, it goes like this, it goes like this, then the tongue has come. These are little reverberations coming up. And these reverberations generally indicate that if they are very, spiky, they indicate that patient has got a soft palate which is reverberating with the air, which happens in patients of obstructive sleep apnea. You can pick up these patients that they have obstructive sleep apnea. So that's it. Yes. It starts from TLC and then ends at residual volume, and then from residual volume, inspiration to TLC, and then exhale out. Right? Thank you very much. That's the second case. Any other volunteer? I think I have just 2, 3, 4 minutes. So if somebody's, yeah, please. You will be teaching, I'm sure.
Never mind.
The FEV1 by FEC is more than 100.
Yes.
So
So
this-
please remember this thing. This is useless. Please do not. I do not know, Nitin, why this all stupid machines give this percentage of percent. Who wants to see that? We want absolute percent. Absolute percent is 82%, 82.56. So please take home this message very clearly. Never ever read this. Ignore this completely. It is in the systems, it will come in every system, but it has nothing. It is a percentage of percentage. Who wants that? We want absolute percentage, and absolute percentage is 108. You are right. It's normal.
Okay. Then FEC.
Correct. So
is
if
low.
the percentage is normal, then you go to the FVC. 100% correct. We go to FVC, it is coming 73%.
Low.
It's 73 on the top.
Yeah.
And after the bronchodilator, it still remains 72% and there is no change at all. So FVC is reduced. So FVC is reduced means it can still be obstruction or restriction, but sorry, it's a true restriction or a partially obstruction which gets relieved with bronchodilator, but it didn't. So even if you look at the ratio in the post, it is 83. So that means there is no obstruction in this. So what we will say this? It's a restrictive defect. 100% correct. It's a restrictive defect. I think my job is done. So we do the total lung capacity and you can see that 67%. So remember one more thing. Never say that this is a restrictive lung disease on the basis of spirometry, because restriction is only confirmed on total lung capacity. The confirmatory test that it is a restrictive lung disease is this, 67%. You can see the red flag out there. Remember that. Obstruction can be diagnosed on spirometry by all confidence, but not the restriction. Because of the air trapping which can happen in obstructive diseases which looks like restriction but is not restriction. I think that is a little complicated. I'll leave it. I come to the last case. Any more volunteer for this? Any more volunteer? Nobody? Come on. 2 more minutes. Anybody? They're scared, I think. Nothing can go wrong. Come. Come. Any one of you come. Both of you are very young people. Come. Why you are scared? Yeah, take this. Yeah, that mic is there. Yeah.
Sir, in the ratio,
Yes,
it
this is the ratio line.
80%. Sorry.
This is predicted.
80%.
This is the one.
Yeah,
64.14. Now look at this stupidity. Clearly it is showing obstruction, it is showing 80% of predicted. What does it mean? You get confused. So please delete this percentage of predicted one column from your minds completely when it comes to FEV1 over FVC. Percentage of percentage will never be there. So this column should never be read. So 64.14. So there is obstruction. Yes. So now you will look at it. Second parameter?
FEV1.
Very good. FEV1. 1.4 to 54%.
54%.
Confirms
So
that there is obstructive airway disease. Then you look at FVC. 73%. Now there is a problem. Is it obstruction only or it is added on with the restrictive defect? So it will be reported as a mixed defect. But we will wait for the post test. 73 to 74, it has still not reached 80. So there is an amount of restriction which has been still left. It could be air trapping, but that can only be determined by the total lung capacity. Have you understood what is the importance of total lung capacity? At this point, whether it is really a true restrictive defect along with obstruction, which can happen in emphysema, or it is an ILD associated with COPD, anything like that, whatever it is. So it has to be confirmed by TH. And then it comes to reversibility. And reversibility is 6% and it is coming to just about 80 ml. So you will say non-reversible. Non-reversible, mixed airway obstruction and restriction defect. The question which comes is that where is the... Oh, curve is not there. I'm so sorry. Curve was not there. Otherwise, you look at the curve, which is the predominant one, right? Anyways, I think I've done my job. And this is again one of the pictures which just tells us how it is going about. So thank you very much. Excellent. I think you should all give a big round of applause for all three people who came forward and actually contributed to that the justice has been done to the talk. Thank you very much. I know that when you people said that, you know, they have a high hopes, what I'm going to do, I was very scared. But if you people have got the message, I think that's basically the idea of the workshop. So I think the rest of this will be taken up when the procedure is shown. It is very important that you people see how the procedure is done. Because if you train your technician, then he will be able to do it blindly correct every time. But you need to train your technician. So with that, I would like to thank you all. I am open to if any questions are there.
Thank you, sir. It was an excellent talk.
Yeah.
In fact,
This patient is on ventilator? Okay. Riles tube is there. Okay, so for Riles tube, we don't, it doesn't interfere at all actually, because then it's from the nasal cavity. And anyways, we are going to block the nasal cavity. We do it for the Riles tube patients. But generally, you know, the question is that how is it going to change your management for such patient? Correct, very correct. So some patients for the surgery, particularly carcinoma surgeries, which are big surgeries, they require it. We do it on the Riles tube also, because Riles tube does not interfere with that. But yes, these patients are generally fragile and quite weak people. So we find most of the times they produce restrictive defects. So we cautionally interpret that. Correct. I know where you are driving me to, but this we do not do. We do not do that. Actually, you can attach there and do it. We used to do it long ago, but now we don't do it actually. If the tracheostomy can be taken out, we generally close and then do it and then put it back. That's how we do it. We don't do it on tracheostomy by putting a mouthpiece out here. We don't do that. Yeah. Thank you.
Thank you. Okay, thank you, Dr. Talwar. I'm sure we all have lots of questions. I have lots of questions, but not now. The time is running out, and we'll move on to the next talk. Thank you. It was a very fascinating and very lucid talk. Thank you.
Thank you very much. Thank you.